Welcome, welcome, you guys. Happy Wednesday. It is mid-September. I was driving around my neighborhood this weekend and there's already Halloween stuff up. And I just felt a bit overwhelmed, a bit behind in my life, but also like shocked that we're already in the holiday season. So I don't know if y'all are feeling the same way, but that's how I'm feeling today. Also, does not feel like fall because in Houston it's like 100 degrees. So anyway, good to see you all. As you guys may or may not know, I am solo today. Chris is traveling. He is on his, I think he's in like Norway and hopefully having a ton of fun. Maybe he'll send us some pictures that I can post the next couple weeks because I think I'm the coverage for 3 weeks. So you guys will see just me 3 weeks in a row. But it is so good to see you guys. I love y'all. I hope y'all know that. And I'm excited to be here. Today it is just an Ask the Expert. So it's going to be me and you talking. And so my goal is that you're going to put as many comments, questions, topics that you want to cover that you have in the comments pane so that we can get to that today. Otherwise, we have a million pre-submitted questions, so we will certainly hop to those as well and bring those up. But as you guys know, always want to get started with just a little couple reminders and housekeeping. The IOCDF webinars and live streams are intended to be educational and hopefully supportive in many ways, but they are not intended to replace therapy. If you're feeling unsafe or suicidal, please call 911-988, go to your local emergency room. IOCDF and or our live streams are not a crisis line and we cannot triage crisis, but we want you to triage that and take care of yourself. What is the other big update? 1 month away from OCD week. So mid-October, the second week of October is our OCD week every single year, and IOCDF does an incredible online conference. You can go to iocdf.org, learn about the conference, see all about it, and hopefully you'll join. Many of us are going to be speaking and be there, and we're just super excited. So yeah, so excited to be here. Let's hop in. We have a lot of pre-submitted questions. I'm going to pull them up on a different page so that y'all can still see me. So give me just a second and hop into those. But of course, if you have questions along the way, please put them in the comment or question box on the right-hand side. All right, first question. Hello, I have a client in a residential program for folks with intellectual disabilities. He's not appropriately placed and also suffers from ASD, but is above average intelligence. Are there resources for folks suffering with comorbid OCD and ASD? Residential programs for OCD have denied him. So this is really interesting. And I will say absolutely, our program, OCDI Texas, we absolutely treat comorbid OCD and autism. ASD is autism spectrum disorder. So it is something that we do all the time. We treat and specialize in, and there's certainly programs that should do that. Of course, there are some restrictions in the sense that most residential programs ask that patients have the ability to engage in some life skills independently. So taking a shower, being able to cook meals, that sort of thing. But most residential programs like ours are happy to assist and coach and teach that as long as patients are capable of it. That would be a question we would ask. But 100% OCDI Texas and many other programs should absolutely be willing to take patients with comorbid OCD and ASD and be willing to help treat both and help give appropriate skills and tools. Next question is, I'm a counselor for a 19-year-old man who has been suffering from countless OCD symptoms for about 4 years. While his parents are looking for CBT services, he seems to maintain some misunderstanding towards CBT and as if he traps himself in psychoanalysis. I'm wondering whether the experts have any expertise in persuading or guiding OCD sufferers to try CBT. This is such a good question. And I think I'm going to have John Grayson on with me in the next couple of weeks. And so him and I will talk a lot about this, which is readiness. We're going to talk a ton about what does readiness look like? Why should you engage in that? But the first thing I'll say, I don't want to persuade anyone to do ERP. I should not be persuading you, convincing you. Instead, actually, you should kind of be persuading and convincing me. I should be educating you and I should be doing some readiness. So helping you see the benefits that CBT and ERP work can provide to you, helping you see and understand why this can change your life and change your relationship with anxiety and OCD. But I should not be convincing you to do ERP or to do specific exposures. And so I think what's really important, especially with patients who've had experience with other modalities, which by the way, most people have, right? Most people have tried talk therapy, maybe they've tried EMDR, they've done neurofeedback, like all sorts of different things, and they haven't seen success. That's something I want to talk about first, right? Can we see that while there may have been some utility or benefit in this intervention for certain things, that it actually didn't probably significantly improve your OCD symptoms? If it did, you wouldn't be in my office, right? Understanding and wanting to do ERP, but also your life would look different, right? Your OCD would not continue to be all consuming and impacting your life. And so I want to make sure patients really understand that and see that. And then we really want to dive and jump in. The second thing that's really important is for us to really understand that for many patients, we're actually not doing ERP or even direct CBT early on in treatment. For a long time, we are doing what's called psychoeducation, where we're helping you understand your symptoms, understand the cycle, understand the ways you feed or enable or empower anxiety or OCD so that you can understand why you need to break that. But you're at a place where you need help breaking it. And in which case, we can really start to lay the groundwork for ERP and CBT and how we can effectively break that, if that makes sense. So, yeah, that's my answer to that one. Why does it happen to get such intrusive thoughts? And we know they're just thoughts. We're trying to get out of them, but we get into them again. And this is such a great question. And obviously, one that is something everybody with OCD deals with, right? Which is that individuals with OCD have intrusive thoughts. Individuals with OCD have insight that they often know this is intrusive, this doesn't make sense, this is bizarre. However, they get stuck in the what ifs, right? And so we know sometimes that these thoughts don't make sense. We know that engaging with them keeps us stuck more, makes us more sick, all of the above, but we can't seem to not engage, right? We can't seem to disengage. We struggle to be able to do that. And so what I am here to say is that you actually want to change your behaviors first. So, in order for us to start to have a different relationship with our thoughts and anxiety, in order for our thoughts and anxiety to have less of a hold on us, less of a pull on us, we actually need to start responding to them differently first. And then the way we feel about them, the power that they have will follow, right? Like that will change and shift after we've changed the way we respond to it. But imagine if every time we get a thought, we respond to that thought as if it's dangerous, it's scary, we need to fix it. We're sending the message that we can't tolerate it, that it is dangerous and scary. I want us to consistently be sending the message that I'm not afraid of this thought, I'm not afraid of you, and I'm not scared of you. And so behaviorally, I want us to respond without acting really scared, without acting as though we need to fix it, if that makes sense. Next question is, my real event turned into false memory, and I started getting thoughts, which feels real, that I have anxiety that I've harmed my nephew when I was driving the motorbike and my nephew was sitting behind me. So this is so common, right? And this is exactly actually what real event OCD is real event OCD is the type of OCD where something does happen, right? There is a situation that occurs that later we start getting triggered about and or our OCD starts twisting what happened in that event, right? Do I remember it clearly? Did something happen that didn't? Or we have this thought that I harmed my nephew and we start trying to confirm or deny it, but unfortunately we can't really figure it out. And so what do? We treat it as we do other OCD, right? We're able to say to ourselves and move forward through that. So we're able to say, okay, like I'm afraid I might have harmed my nephew and I really want to figure this out and solve it, but I know that's going to keep me more stuck. So I'm going to choose to not figure it out and move forward anyways. And I'm going to go play basketball with my nephew today or go do a values-based activity, still go have fun, enjoy time with your nephew. You don't have to avoid him, which also, again, sends that message that I can't be around him, I could harm him, right? But what we want to do is we don't want to try to get stuck figuring out and solving it, because when we do, what we're actually doing in that moment is we're just engaging with OCD. And the more we engage with OCD, the more we feed it, the bigger it gets. We really want to starve it across the board. I have emotional contamination. What thoughts of a person I don't like freezes my actions? There's not much literature on this. Can any books help? So definitely check out our lunch and learns and our different webinars on IOCDF's YouTube channel. I think we've done one on emotional contamination that you can look up. But remember, all subtypes of OCD, while they might seem a little bit different, they're treated the same way. Right. So we are going to treat them with understanding what is our core fear? What are we really afraid of? Right. What is at the core of being, if I interact with somebody who feels emotionally contaminated or who I'm triggered by, that's what I want you to focus a lot on is, okay, what am I really afraid of? And then we're going to start actively doing ERP. So being around those individuals that trigger us, not doing any rituals, allowing space for our core fears to come up and moving through them. That will allow us to change our relationship with the core fear, with the intrusive thoughts, with the exposures. And it also will start to lessen the hold and the power and the grip that they have on our life. I'm going to hop into some live questions. At 11:02, why does OCD target what you most love and care about? I just don't understand why it does this. Same. I think this is the question that everybody wants to know is, why can't my OCD target things that don't mean a lot to me, right? Why can't my OCD be focused on something that doesn't bother me as much, that isn't as big of a deal? And unfortunately, what we know is that it actually probably kind of does to a degree, in the sense that what I want us to remember, intrusive thoughts in and of themselves are not unique to OCD. People with OCD, people without OCD have intrusive thoughts. The difference is that our thoughts are sticky, right? They are coupled or joined with anxiety and distress. They make us feel really uncomfortable. And so we have the urge to fix them, to figure them out, to understand them. Because we don't like how they make us feel, right? And the fact that they're accompanied with these feelings make us think they're really real. When you have random intrusive thoughts, which by the way does happen, about things that don't matter that much to you, that you don't love or care as much about, you are able to allow that thought to come in and allow that thought to move out, right? So it comes in and out. You kind of move through that without responding to it. But when someone with OCD, it attacks something we love or care about, we get stuck, right? That it feels like there's more power, there's more weight. Oh my gosh, I need to fix this. I need to solve it. And so what we always say is that OCD always attacks what we love the most, what means the most to us. And it's not because it doesn't, you don't have intrusive thoughts about other things, but the reality is that because those other things aren't as valuable, meaningful in your life, you're able to have that trigger and move through it. There was a question from Nathan about medication. I don't know the answer to that, but we will certainly add that to our medication questions. And I believe we're planning to have psychiatrists coming on in an upcoming Lunch and Learn, so we will cover that at that point. So good to see you guys. Love hearing, seeing all of y'all chat with each other. How would you advise someone to overcome self-loathing in the context of OCD recovery? So one of the ways I would encourage you to do this, I was looking behind me, is to buy Kim Quinlan's workbook on self-compassion and OCD, right? So number one is, can we start to understand that there are actually ways we can do exposures that allow us to feel better, that allow us to get closer to the things that are important to us, the things that we love in our life, and that align with our values, right? Not all exposures have to just be this terrifying thing that we do to try to get our anxiety high, or this terrifying thing that we do to trigger us. And so it's really important to keep that in mind and to remember that. What I will also say is that I think that it's so important for us to remember we didn't ask for our OCD. We don't want our OCD. We don't like our OCD. It goes against our values, who we are and who we are as a person. However, we can have the strength to work through it. And what I want us to believe is that those who go through OCD treatment will be stronger and in fact better than those who don't. And yeah, you might say to me, well, Liz, I wish I didn't have to figure that out. And I agree, right? But we can't change that. But a good example is that individuals who really had managed their OCD, gone through treatment, were doing really well, often found that during COVID, they were managing COVID so much better than people around them who had never really experienced that level of uncertainty, anxiety, distress, and they fell apart. Where people who had done OCD treatment were like, oh, I know how to do this. So I also want to say, can we look at the positives that can come with treatment and the strength we can derive from it and the adversity that we're going to be able to have because of it. 1106, is there a connection between OCD and religion? So we do know that one of the common subtypes of OCD is scrupulosity, which is often where OCD impacts or interferes with one's religion, religious practices, that sort of thing. But there is not necessarily a connection that like people of a certain faith are more likely to have OCD versus not. It really affects the general population about the same, but absolutely we know that OCD can impact your faith and impact your religion, and we call that subtype scrupulosity. The great news, once again, is that treatment stays the same. So treatment doesn't change. And it is one of those things that treatment interventions can actually work for any subtype of OCD, effective treatment interventions. It's not like, oh, ERP works for this subtype, but not that type. No, it works across the board and is really, really amazing. Does psychoanalysis do anything for mental health? And, I think there's some research that would show that psychoanalysis can be a beneficial intervention for specific diagnoses. I think like for some personality disorders or at times it's known to be an effective intervention, but psychoanalysis is not known to be an evidence-based intervention for OCD or anxiety disorder. So for most people with OCD or a primary anxiety disorder, psychoanalysis would not be the intervention that you're going to get the most relief from. Amy, I love that. And so Amy's talking about Grayson's question. He asks a lot of folks is he'll say, what has OCD taken away from you? And he doesn't say that because he wants you to just write down and think about all the things it's taken away from you, but he then wants you to be able to turn that into motivation and a motivating factor, right? So, wow, OCD has impacted this in my life. And so in turn, I'm going to fight really hard so that I can get these things back or so that it doesn't continue to impact me in that way. 1107. When you know for sure that you have OCD, I was first diagnosed by a psychiatrist in 2015, and then the same psychiatrist diagnosed me as GAD later. Then I visited another who said I have hypochondriasis. I also have insomnia, and it's linked with OCD. These are all really great questions, Dr. Hassan. So, what I will say is that OCD, GAD, and even hypochondriasis, or maybe we would actually call that health anxiety, are all very correlated, right? And somebody's health anxiety could actually be better defined as OCD. Someone's OCD could be better defined as health anxiety or GAD. The good news is the treatment is very similar. All right, we're going to use CBT no matter what. Obviously, for OCD, we're going to use a specific form of CBT called ERP, where for GAD, we're going to do more exposure therapy, and same for health anxiety. However, what I will say is that it is important to know, what is this diagnosis? Is this OCD and something else? Or is this OCD alone? And I say that because many of our patients that I treat, many people have a comorbidity. So they might have OCD and general anxiety disorder. They might have OCD and health anxiety. And it's important for us to know that because we want to be able to properly identify where each symptom fits. So is this a symptom of my OCD? Is this a symptom of my general anxiety disorder? And y'all might say to me like, Liz, why does that matter? Well, it matters because the treatment is a little bit different. Right? With GAD, first of all, one of the ways we can differentiate GAD from OCD is that GAD is much more focused on general anxiety. So these general fears that a lot of people have. So an example of that might be the fear that I'm going to get in a car accident, so I'm afraid to drive, or the fear that I'm going to get let go from work, so I'm anxious every day when I show up to work. So it's not kind of these fears that are more bizarre in nature, that are more intrusive. It's fears that everybody has, but our anxiety starts to get in the way and those fears become problematic, right? Having thoughts or fears or intrusive thoughts in general, in and of itself, is not actually dangerous. It's the way they impact our life is what makes them dangerous. So, for example, if I have a thought that my company is, I don't know, let's change that. If I'm walking alone in a parking lot in the evening and it's dark and I'm a little bit on high alert because I'm by myself, I feel a little bit anxious, I don't know my surroundings, that anxiety could actually be beneficial to a degree, right? It could kind of keep me safe. If it gets to a point where I can't go out at night and I can't walk to a car by myself and I am afraid to leave my house, now that anxiety is disruptive. Right. So what we really want to know is it disruptive? And then what is it? And so again, the reason it matters of what it is that if it's a more GAD fear, this kind of anxiety that's intensified, we still need to approach it with CBT, but we're going to be doing more exposure therapy because often people with GAD are not doing rituals or compulsions, right? They're often just avoiding. So the big treatment is exposure. It's getting back, no longer avoiding, reintegrating in your life. However, with OCD, individuals are also doing rituals. So exposures alone, right, going back and doing this thing you've been avoiding isn't going to be helpful if you're still ritualizing. That ritual reinforces the OCD and like keeps you more stuck in the cycle. So it's really important for us to understand, is this OCD? Is this GAD? How do I differentiate it? Because again, the treatment looks a little bit different, and I want you to be able to know how to approach that in that moment. And so I will actually sometimes pull up a chart with my patients and say, okay, this is your OCD, and this is, let's say, your personality disorder characteristics or something else that's going on. And here's how we differentiate what shows up when, and here's what the treatment would look like for each so that we understand that and we can feel really good about that. Insomnia can definitely be linked to OCD. Insomnia fears can be OCD fears. So that fear of like, I'm not going to get enough sleep. And if I don't get enough sleep, I can't function, and having kind of these irrational fears. Or insomnia can be kind of standalone. It impacts us. But again, CBT interventions are known to be very successful for insomnia. And one of the most effective, a very effective CBT approach is called CBTI. So CBT for insomnia, that is a specific CBT approach for insomnia. So many of y'all, sorry, I love your questions, just kind of going through it. I love that y'all are chatting with each other and catching up. At 11:13, would you advise someone in recovery from OCD to still do planned exposures at specific times, or is it unnecessary? This is a great question. And I get this question. I've said that a million times, but I get this question often. And people will even ask me, Liz, do you still do planned exposures? My answer to that is if I need to. So I'll give an example. Right now, my OCD is pretty well managed, significantly managed, I should say. And so I don't do planned exposures because my, like, what I would call, ERP every day is actually just living my life, going to work, being with my kids, being with my family, like the things that I do. That in and of itself, if I was triggered still, would be an exposure, right? So living my life, I don't need to do planned exposures because OCD is not significant in my life right now. However, if OCD is more significant, what that means is that we automatically would both have the urge to avoid those things that would trigger us. And we often would, when we do those things, even if it's just through living our life, we would be getting the urge to ritualize. And so the reason in that moment we want to deploy or engage in planned exposures is because we want to get to a place where those things are no longer triggering. We want to get to a place where we don't feel like we're having to debate with OCD and having to go back and forth, if that makes sense. So it can be very necessary, but if you're doing really well, living your life is much more necessary. But what I would say is, if you feel like, man, I'm starting to avoid things, or wow, I'm starting to get pulled in to want to ritualize around certain things, that's when I want you to really slow down and engage fully at that point in doing some planned ERP. COVID caused the OCD to get out of control and I went into depression. Yeah, we definitely can see triggering events really increase OCD, any mental health symptoms, right? We're feeling more vulnerable. There's a lot going on. There's that extra layer of stress, an unplanned pandemic, right? All of these things, of course, could contribute to anxiety and OCD. And then what we know is that at times depression can follow. So that's 100% not just valid, but something that we want to be aware of. We want to give ourselves grace around. And can we now re-engage, right? Can we do ERP around where OCD still sticks, and can we address it? Next question from Dixie. I have struggled with OCD for 20 years. I've had TMS intensive 5-day treatment medication. On top of that, with a top-notch specialist in New York, while Behavioral Institute intensive for a month virtually. I've always been terrified to go to residential program. I now feel I can do it. However, they won't accept me because they said I'm not in current ERP treatment. My problem is I've run out of funds completely on my disability. I would love to get a job, and then it cut off. Sorry. Okay, so this is a first of all, I'm so happy that you are at a place where you're ready to do treatment and you feel like TMS and these other interventions have gotten you to a place where now you can do ERP. So that's amazing. If you were talking about a place like McLean Boston, because I do think McLean Boston is probably one of the few that takes your insurance is a guess that I'm making based on what I'm reading, I would still get on their wait list and start to do ERP now. It is really important that individuals are doing ERP and have engaged in ERP before they come to a residential level of care. The reason for that is that we want you to have experience. When you get to res, the expectation is we're really going to jump in, right? We're going to be doing ERP quickly, actively, and really doing that work. Then we want you to have a good foundation. We want you to have a solid backbone around ERP so that it can be as effective as possible. So I would say there are options depending on where you live. I would look into academic, institutional options, or any sort of large clinics. So like our clinic, for example, and others often have students and sliding scale options so that there's options available for many different individuals. And then of course, the same goes for anywhere at academics or universities, right? Is that in these academic institutions or universities, they often take insurance, but also have sliding scale and other options available for you to get started. And again, it's not just about readiness. What I also want to say is one of the big questions we worry about when patients show up to our program is, are you going to be able to maintain progress when you get home? And so a big question of that is, do you have outpatient care lined up? And so part of why we also want you to have gotten and received outpatient ERP prior is that we want you to have that to fall back on and to go back to when you leave treatment. We wouldn't want anyone to come get intensive res treatment and then leave without an outpatient ERP provider. Next question, isn't avoidance itself a ritual or compulsion? Yes and no, right? So the answer to that is yes, it feeds OCD the same way as a compulsion. And in fact, what I would say is that when you're engaging in avoidance, sometimes that's actually worse than individuals who are engaging in compulsions. Let me explain why. If you are avoiding everything, it actually kind of prevents you from having to do compulsions. And so oftentimes people with OCD, they'll start to justify, well, I didn't really want to do that anyways. I don't really need to see that friend. I didn't really want to go to that movie. I didn't really want to go to dinner. And it's really like, I didn't want to have to face the distress and the anxiety and the compulsions that I would be faced with if I went. But the reason this is so important for us to be thinking about is that in order for me to help you, I need you to be re-engaging with life. One of the biggest things I see you guys across the board as a treatment interfering behavior is somebody not having goals and a plan to return to. It's like, oh, I'm going to get treatment to get better and then I'll figure out what I'm going to do next. No, during treatment, I want you starting to look for jobs, volunteering, going back to school. I want you to start to have things that really motivate you to fight your OCD. And so when people are avoiding and they're not compulsing, sometimes they're like, well, now you want me to do things I don't really want to do anymore. And I might do compulsions. And so I have to be annoyed with that as well. Versus somebody who's still doing life, still engaging in those values-based activities, but they're doing compulsions, they're much more motivated to want to reduce those compulsions, if that makes sense. So my goal for them is to reduce the compulsions. I don't have to get them re-engaging because they're continuing to engage in life. But it isn't a compulsion itself because a compulsion is a behavior you're doing, either a mental behavior or an external physical behavior like a hand wash or mental prayer or something like that, versus avoidance is we avoid the entire situation that would trigger us. 11:21. Hi, everyone. Great Anxiety Society podcast. I especially enjoyed the ones that were about self-critic and anxiety and social media. Thank you. Thank you. So for those who don't know, our clinic has launched a podcast called the Anxiety Society, and we love it. It's an incredible free resource available to anyone. And what we really are doing is saying, okay, what are all the tips, tricks, and tools that being OCD and anxiety providers has taught us that the general population could probably benefit from, and doing our best to disseminate that. So thank you. I love that feedback and hope you guys are enjoying it. Yeah, absolutely. Gail's talking about how after lockdown, you couldn't go to shops. Your anxiety was on an all-time high and OCD and compulsions were hectic. I completely relate. Maze, I might have missed a question because it says that Liz is one of the authors, so I need to get back to that question. Sorry, I missed that. So at 11:18, May said, thank you. Look how fast you are on the back end, Amanda. You're impressive. Is it more difficult to achieve positive results the longer a person has OCD? I've lived with OCD for 20 years and just started therapy. ERP seems overwhelming. Number one, yay. I am so happy that you're seeking treatment. And it doesn't matter when we seek treatment, it's about seeking effective treatment. What we know is that treatment can be effective at any age. We've had individuals in their 70s, 80s come to our residential program and their life completely changed, then be able to leave free from OCD. So it doesn't actually matter how long you've had OCD. What I do often find is that the longer individuals have had OCD, now we have to start to also do much more, sometimes, work around self-compassion, identity, re-understanding re-understanding our identity and who we are, re-engaging in life activities, because we've withdrawn from a lot of those if we've had severe OCD for a long time. But therapy works the exact same. And ERP does feel overwhelming at the beginning, right? You hear about, oh my gosh, you're going to have me doing all these things I haven't been doing for years, facing these fears. But ERP should feel rewarding, it should feel freeing, and it should feel beyond empowering. And so, although it seems overwhelming in theory, that's totally normal. In practice, when you start doing it, you should be able to feel really empowered and really proud of yourself. Love it, Amy, sharing your example that you kicked OCD to the curb after having it for 40 years. That is so incredible. Um, David, I think that your question around like time of year, this is normal, right? We see OCD symptoms ebb and flow, and so do vulnerability. So I would kind of want to know, what about the fall is more triggering to you? Is it that you're not as busy? Is it that like school's back and people are right? Is it that you're busier? Is it that you don't love the season? Although fall compared to summer in Texas is great. I don't know where you live, right? But is it that like, oh, the winter, that means winter and cold weather is coming, right? But what is it that kind of changes your mood or affect about the fall? And we want to really approach and work on that. But we definitely can see that certain times of year, especially like holidays, more stressful times, right? 100% we can see things increase. Think about with kids, right? Start of school. My gosh, if they have anxiety in the school, we're going to see it totally increase compared to start of summer and how they feel kind of relieved and in a different place. Grace said at 11:24, I've realized that during ERP, I'm still fearful of accidentally staring at people. What's the best way to ease into being comfortable in these situations? So, Grace, we've actually done an entire webinar on staring OCD, and so I definitely recommend checking that out. Again, you can go to the YouTube channel and IOCDF to look that up and see that. But what I would say is to remember, we're going to be afraid of our fears until we start doing exposures around them. So many times we want to feel comfortable first, but what we know is that that's actually not how treatment works. We need to change our behavior first, and then feeling more comfortable will come next. So the best way is to start to put yourself in social situations, start to do these exposures, and what you will see is you will feel more comfortable after, but you're not going to feel more comfortable first. And this is that kind of really hard thing for us to wrap our head around, and that none of us really want to sign up for, right? Okay, sign me up for something that feels terrible. Like, no, I want to feel good about it first. But what we know is that it's the opposite, right? Think about anything like getting up in the morning, right? Most of us, if we're tired, we want to hit snooze, we don't want to get up. But once we get up and get going, we feel much more comfortable about being up and less tired. But if we stay in bed and avoid getting up, we continue to feel more tired and drowsy, right? But there's so many things in life that we have to change our behavior first, and then those feelings follow. OCD and anxiety is no different. Okay, great question, Deleuze at 11:24. So I'm going to go back to this. Deleuze is who asked the question about like how often do we need to be doing like planned exposures and what does that look like? And then you said the reason I ask is because I'm not sure if the emphasis should be on response prevention or the exposures, but I'll keep it in mind. I usually focus more on preventing rituals when I come across a trigger. So you're doing everything right. So absolutely, the focus should be like much more on response prevention. So Alec Pollard's famous saying is like, I'd rather it be a small exposure and huge response prevention than a big exposure but small response prevention, right? Because the response prevention is what actually allows us to change our entire relationship with anxiety and OCD, not necessarily the exposure itself, right? People could do exposures all day long, but if you're doing rituals, you're reinforcing your OCD and making it worse, not actually making it better. You have to be doing response prevention. And so again, what I would say though is that if you find you come across a trigger once every couple weeks, once a month, and you're like, okay, let me lean into this. Like, you probably don't need to do planned exposures. But if there's certain things that every day are triggering or that continue to be a constant theme, I want you to slow down and do active ERP with core fear work around those specific things so that they don't continue to be triggers, right? So it's kind of like, oh yeah, do I have this like random trigger that sometimes gets me and it's on occasion and I can just, it's not that I have to slow down and focus on it? Or are there triggers that interfere with my life and daily living frequently, in which case we do need to slow down and do active ERP for those? Um, Karochi, you can just put any questions in our chat anytime. Thank you for joining. I love that you just joined us. And so yeah, the way these webinars work is that anytime you guys join, you can put questions throughout. If we don't get to them, we add them to a file that then we do our best to get to them. We have webinars every Wednesday at noon Eastern, every Tuesday at 7 p.m. Eastern. Tuesday's webinars are focused much more on community conversations. So these are often led by our advocates, and we do roundtables, and it's really a conversation for the community. Our Wednesday webinars are focused and led more by clinicians. So we're answering specific clinical questions. We're going through treatment updates. We're going through OCD stuff, related disorders, kind of you name it. So that's kind of how these webinars work. But I love that you guys are joining and that we have so many new folks. It's so good to see you guys. Thank you for saying hi. Love that we have individuals from Japan and all over. I love, love, love this. Delu said, I also wanted to ask, is it possible to see a therapist out of state if you don't legally reside in the state that you travel to, but you travel to that state temporarily? So the answer to that is yes and no. So I say we, like I'm a policymaker, I'm not. Policymakers, are working to try to change some of the restrictions around licensure. As of right now, you can only see people if you're licensed in their state. There's a couple exceptions to that, like PsyPAC, which is a program for clinical psychologists, where if they're a PsyPAC member and have a PsyPAC license, they can see individuals in other PsyPAC states. So what you really want to know is, do you practice in the state I reside in? The reason this is important is that even if you're doing virtual sessions, oftentimes OCD impacts your home living, and we need to really do exposures in that arena and in other arenas. The second piece, though, is that, we don't have the same resources in other states that I do in the state I reside in, right? I have a lot more resources if something else is going on. If I think you need another assessment, different interventions, I have those resources because I'm in that community, I'm in that state, and I might not have those in another state. But we really want to be licensed there. You can travel to states to get treatment. So great examples, our residential program, right? At OCDI Texas, we are not we're not treating majority of people from Texas. We're treating people from all over the world, actually, and they can receive care if they're in our state. So when they come here and they receive that. I would not recommend that somebody travels to a different state to receive outpatient care, because outpatient care is longer term, it's once a week. But when we're talking about intensive treatment, it's very common for people to travel to that state to get the treatment. In Eduardo at 1129, is feeling dread and massive anxiety a part of OCD? I get certain images and thoughts and feelings like that. So yes and no. So dread and depression can follow an OCD trigger. So an OCD trigger can absolutely bring on anxiety and dread and distress. Anxiety and dread itself doesn't necessarily mean it's OCD. So an example is somebody can be living with depression and feel massive anxiety and dread. Somebody can be living with a different disorder and feel anxiety and dread, but not have OCD. So it can be, but anxiety and dread itself don't tend to be an OCD symptom. They tend to be something that happens because of OCD, if that makes sense. So I'm really triggered by something, I'm frustrated because I can't perform the way I want to at work or in my home life, and my OCD is impacting my life. And then it brings on these secondary feelings of dread, of anxiety, of distress, that sort of thing. In that case, we really want to address OCD and see if the dread and anxiety shifts. But if there is a standalone or another diagnosis of OCD or dread, in the sense that like a standalone diagnosis of general anxiety or of depression, right? We need to be treating that at the same time. So your provider should be able to kind of differentiate, do we think this will change if OCD changes, or do we need to be treating this at the same time, or maybe even first, right? An example of that is patients with severe depression. We often want to treat their depression if they have severe depression on its own as a primary diagnosis before we treat OCD. Why? Well, because if somebody's severely depressed and they're not getting out of their room, they're not eating, they're not participating in life, it's going to be really hard for them to engage in ERP treatment. But if somebody like myself had depression due to my OCD, so my depression was secondary, I wasn't depressed in general, but I would avoid doing things because of my OCD, and then it would bring on feelings of depression. For me, treating my OCD also in turn treated my depression, right? So we want to really look at, where does it fall? Like, is this a primary diagnosis? Is it secondary? And that's something that you and your provider should really talk through on your own. 1113 from Brooke. My daughter is 13 and struggles with OCD and has been diagnosed for several years. We've tried several things including medication. How can I know she's ready for ERP, or any suggestions on how to support her, give her coping skills, resources, help, or support? Thanks for asking this question, Brooke. So what I would say is that if your daughter has OCD, she needs to do ERP. So you don't need to worry about a patient like doing other things or doing other treatment before they get ERP treatment. We actually want to start with ERP treatment. A really good ERP provider is going to do readiness as a part of their treatment protocol. So they are going to help get the patient in their own therapy process ready for ERP, ready to engage in ERP. So the provider should be doing that, not you. At the same time, we don't want you to sit and wait to do ERP, if that makes sense. At 1134, when going to work, OCD becomes stronger, then difficulty in when applying ERP, and how to manage this and work together. So, we hear this often where a lot of individuals will say things to me like, well, Liz, I can't work right now because of my OCD, or, it's really hard for me to go to work, engage in work when I'm triggered and I'm doing these things. And I think that's true, right? I mean, that's your experience. Like, that's true. And it's also really important that we get you at work and staying active, because what I would also say is that sitting at home, not going to work, being quiet with your OCD and your brain is also not going to make it easier to do ERP. It's also going to be very hard to do ERP and be very triggering. Now you might say, well, yeah, but when I'm home, I'm not as triggered, right? Because I can avoid some of these triggers if a lot of the triggers are at work. And again, while that's true, we don't want to avoid triggers, because when we do that, we're sending the message that we can't tolerate them. We can't tolerate hard things. We're not capable of doing this exposure. So we want to be really thoughtful about what exactly is the message we're sending to our OCD? What is the message we're sending to our anxiety? And how can we change that message? I want to ask y'all for a second. I'm going to give you a second to think about, what do you think is the message across the board that I want you to be sending to your anxiety and OCD? What do you think? Do you think it's that OCD is scary? Do you think it's that anxiety is dangerous? Do you think it's that it's so hard? No. My favorite analogy I tell people is, I want you to have a bring it on attitude. I actually want you to look, anytime anxiety or OCD throws something your way, I want you to look at it as, I'm not, I'm not worried about it. Bring it on. Is that the best you have? What else are you going to throw at me? Right? That's the message I want you to really be sending, is I want you to have this bring it on. I am not afraid of you. I'm not afraid of what you throw at me attitude. And I am going to approach you at all times, versus, please don't bring that up. Please don't let me have that thought. Please don't let me have to face that trigger, right? That is going to get you more and more stuck. You guys are so many questions. I can't breathe. I'm trying to read them all and I'm stuck. When go, okay, I already read that one. Next question. 1136. I came to San Diego and have lots of anxiety when I look at the sky. I've felt being close to a panic attack several times. Should I still expose myself? So the answer is absolutely, right? Remember, we don't want to send the message that anxiety is dangerous. If we know we get anxious when we have certain thoughts or look at certain things, the more we avoid it, the more we're empowering our anxiety that, hey, looking at the sky is going to make you anxious. Doing this exposure is going to trigger you. And so instead, again, we really want to approach things. Love this feedback about stick with the ick and different groups that you guys can join. IOCDF advocate stuff. Love all of this. 1137. How'd you make the choice that you were willing to stop ritualizing in exchange for getting your life back? My whole life is an exposure and I just went back to work. Congratulations, that's so exciting. My contamination issues affect me getting back to my desk. Any advice is appreciated. So first of all, Madeline, congratulations on going back to work. That's so exciting. I get this question a lot, and I feel like there's so many times where people want me to be able to give them this aha moment, like this, oh, this happened, and then all of a sudden I was able to do things differently, or I was able to no longer engage in rituals, or and the reality is that that actually isn't what came first. I didn't have an aha moment first. Instead, I had to make the choice that I am done with this. I'm done negotiating with OCD. It always wins and it disrupts my life and the things I want to be doing and the things that are important to me. And when I made that active choice, I was able to start doing things differently, which means not giving into rituals, not getting stuck, all of the above. And so I really want to push you guys to be thinking about that and to be saying to yourself, okay, can I write down my greater good goals? What are the reasons I want to fight my OCD? What are the reasons I no longer want to do rituals? What are the things it's taken away from my life? What is the impact it's having? What is the time it's robbing? And I want you to start saying, I'm going to make the choice to do something different. And I get it, guys. It doesn't feel like a choice in the moment. When you're riddled with anxiety, when you feel this distress, it doesn't feel like you can make that choice. But what I want us to remember is that when we make the choice to ritualize because we want to feel better in the moment, we're also making the choice to empower our anxiety and OCD. And my goal for everybody is that you're making the choice consistently to empower your life. Madeline, I want work to be exciting and fun and challenging because it's work, but not challenging because OCD is there and because triggers are there and because it's tough for you to be at your desk. And so I want us to remember that the goal and that we know that we have the power through behavior, right, to change the way OCD and anxiety impacts us at work and for work to be what it's supposed to be versus what OCD is making it be currently. At 11:41, during the process of ERP, does medication become an option at any point? Absolutely. Most individuals with OCD, engage in therapy and medication. It's often something that people do both versus one or the other. So absolutely. I'm still wondering how to manage all or nothing thinking when it comes to OCD, because it does seem that if you let OCD run your life, it'll become small, but catastrophizing is 100%, right? In life, anytime we get into black and white, all or nothing thinking, we get stuck. And it's really hard to change that relationship. Many people do have comorbidities. I see a lot of you guys sharing that. Hi from Japan. Hello. Thank you for the amazing information. I suffer from fear of harm and intrusive thoughts. What should I do? So again, first thing is we really want you to get with a provider who understands OCD and specializes in ERP. And we want you to slowly start engaging in ERP, right? Slowly and surely, we want you to start doing ERP treatment. Next question. I'm scheduled to have my first ever consultation with an actual OCD therapist specialist. Yay, this makes me so happy. I would appreciate any advice to make the most out of my appointment. All right, let's talk about that. Number one, I want you to remember you're kind of interviewing them, right? When you're coming to see us, you are kind of interviewing us, right? So when I come to see you in treatment, the first thing that's really happening, or sorry, you come to see me in treatment, and maybe I'm going to see a therapist too, that can happen, is I want to make sure that we can have a relationship and rapport together. But also, candidly, like, I want to know, do they understand ERP? Can they treat OCD? Do they have background in specialty? And so I want to ask questions like, this is my OCD. Have you treated cases like this? And where did you get your training and background, right? All of those different things. So I think that the most important thing is making sure you feel comfortable and confident, and you should leave a session with an OCD specialist feeling excited and hopeful that they're going to be able to help you change your relationship with anxiety and OCD, give you tools, resources, support that you haven't been able to get on your own. Love, love, love. So many of y'all's comments. Y'all are so great, motivating to each other. I just love this. And I love love y'all's feedback. So last question is, what do you do if OCD gets its power because you have fears of not getting better? What exposures can you take? So this is something a lot of people struggle with, right? That fear of, I'm always going to struggle. I'm not going to get better. Guess what? You have that bring it on attitude. That like, okay, like thanks for telling me that, OCD, and I can't wait to prove you wrong. You start doing the things that OCD tells you can't do. You start engaging with friends. You start going on dates. You start applying for jobs. You go back to school. You do those things to behaviorally show you don't believe that narrative OCD is telling you. I don't believe the narrative that I'm not going to get better, that I'm going to get sick. And guess what? My actions can show that I don't believe it. However, if it becomes kind of this self-defeating prophecy in the sense, or self-fulfilling prophecy in the sense that like, okay, we're worried we're not going to get better, so we don't enroll in school. We don't make plans with our friends. We don't start doing these things that we want to do one day because we don't feel like we can. We're sending that message that, yeah, I'm not going to get better. I'm going to stay sick. I'm going to be in this role versus, hey, yeah, I have an OCD diagnosis, but with treatment, I can get to a point where I actually wouldn't even meet criteria for an OCD diagnosis anymore. So again, the message for today, you guys, that I want you to take home is that we make behavioral change first and everything else follows. We want the opposite. We want to feel good about doing something. We want to feel okay about something. We want to believe something first to then be willing to do that behavior. But guess what? That's just not how life works, even if it is an OCD. Right? Sometimes there's things I don't want to do, but I do them anyways. And guess what? They were still enjoyable. Or maybe I even surprised myself, right? Think about times in your life when you didn't want to go out with your friends, or, but your friends drag you out, but you weren't feeling up for it. And you end up going and you're kind of like, man, I'm happy they made me go. I had a good time. You didn't feel excited and happy that you went first, right? You actually kind of questioned if you should go, but you went anyways, and then the feelings followed. So that is how OCD works, right? We're going to feel empowered. We're going to feel excited. We're going to be able to see and understand how we can totally change that relationship with anxiety and OCD, but it changes by us making behavioral change first, not by making behavioral change after we feel a certain way. If we wait to feel a certain way first, you guys, we often won't do that change and we continue to stay stuck. So remember, only you have the power to change how you feel and to change the way your OCD impacts you and to completely change the relationship you have with anxiety and OCD. I want you to empower the relationship you have with your life, the relationship you have with your values, not your OCD. And so we have to make behavioral change first. Thank you guys for being here. I love seeing y'all. These are always so fun. It's exciting. I miss Chris, but I also love getting to do all this and chat with y'all. So please feel free to send us any messages, content, things you want our live streams to cover in the future. You can do that by going to iocdf.org/peace of mind. And of course, I will see y'all next week as you join for our next live stream, which will be, the next live stream with me will be next Wednesday at 12 p.m. Eastern time. And of course, our community live streams will be next Tuesday at 7 p.m. Eastern. Good to see you guys. Thank you and take care.